Good evening, ladies and gentlemen of Westminster. I'm Kathy Kelly, for those of you who may not know me. I'm going to be this evening's moderator, and our program title tonight is Sleep 2.0. Bill Sluice, Dr. Sluice, will be presenting, and our guest panelist this evening is June Foster, who also will be directing some questions to Bill. And I'm sorry to say that our other guest had an illness and he won't be here this evening. So get well, Bill, strong. And let me start with a little bit about Bill Sluice. He has a very long list of credentials and professional associations. He earned his MD at the UT Medical Branch in Galveston. He completed training in psychiatry and psychoanalysis at the medical branch and the New Orleans Psychoanalytical Institute. Bill is board certified in both fields. Bill maintained a private practice in Houston and later in Austin. He served as clinical associate professor at Baylor Medical School and teaching analyst at the Houston Galveston Psychoanalytical Institute. Bill and his wife, Virginia, have both been residents here at Westminster since 2013. In addition to being a frequent lecturer here at Westminster, Bill is an avid sailor and traveler. If you walk along the first floor of the Windsor, you may have marveled at Bill's photographic displays and Virginia's artwork. In advance to both of you, Bill and Virginia, we are grateful for your involvement and community contributions and our well-being visually and mentally. And my other guest this evening is June Foster. June is a graduate of UT, but prior to that had been at Vanderbilt in the School of Nursing for 3 years. She grew up in Rome, Georgia. And after her transfer from Vanderbilt to UT, she got married and moved to Austin, Texas. That's where she completed her studies. And she has 2 children, and her professional career in healthcare management have brought her many far and wide, from Houston to LA and back again. And would like to thank her for participating tonight. And with that, I will say thank you. And Bill, would you take the show?
Good evening, and thank you, Kathy, for that very generous introduction. As some of you may know, this is the second go-round with a talk on sleep. That's why it's Sleep 2.0. The first was a little over 3 months ago now, and although it wasn't the first Westminster residents shown, it was the first recorded, and there was a learning curve involved, and it really wasn't very usable. Also, I've learned a little more about what this series is about, so I have made this presentation a little different, not using PowerPoint. I'm making it a little less technical and hopefully a little more practical. So that's kind of where we're coming from. So why a program on sleep anyhow? Well, we spend a third of our life sleeping, or at least hopefully close to it. So that alone makes it important. Also, people in our age group often have some difficulties with sleep, and so it is an important topic for us. Despite its importance, we really didn't know a whole lot about sleep until about the last 60 years or so. There was long time knowledge of a sleep-wake cycle, and dreams had been written about from antiquity, mostly in very creative and speculative ways, but we won't really go into that very much. But within the last 60 years, a little more, a great deal more has been learned about sleep. There are 2 sort of foundational aspects that underpin our knowledge of sleep and our understanding of sleep problems. The first is something called circadian rhythm. It's really built on the sleep-wake cycle, but it's a cycle that all mammals have, and some non-mammals as well. But it's a little more than a 24-hour cycle. The name actually is circa, approximately, circadian, about a day. Not to be confused with cicada, the little bug that comes out of the ground every 13 or 17 years. I've heard more than a few people conflate the two. Anyhow, circadian rhythm, which is this cycle that a number of physiological changes are tied to, it is very persistent. It's the basis for things like jet lag and the problems that shift workers have when they go from one shift to another. Our sleep-wake cycle, circadian rhythm, is inherent, but it's a little more than a day. It's about 25, 26 hours, but it's reset every morning, sort of like our radio-controlled clocks, by light. And that's one reason it's important to get some fairly bright light every day, preferably in the morning. The other fundamental phenomenon that's only been understood since World War II, really, is the sleep cycle, the structure of sleep. There was some beginning knowledge of this based on electroencephalography, brainwave tracings, before World War II, but most of it was developed after. It turns out that our sleep, we go through a cycle of 4 or 5 stages of sleep every night, repeatedly for about 4 or 5 times. And each cycle ends with a type of sleep that we now call REM sleep, REM sleep, which stands for rapid eye movement. This was first noticed in sleeping people getting an EEG in a lab, and there would be this artifact that turned out to be the potential from the little eye muscles, the extraocular muscles that move your eyes. And at first it was regarded as a curiosity, but a graduate student named William Dement, he was getting a PhD after his MD, headed for a research career, and he paid attention to this and determined that invariably the REM sleep is accompanied with dreaming. If you wake up a person who's having REM sleep, they're always dreaming. Also, most spontaneous awakenings from sleep will be from a REM sleep. We go to sleep, we pass quickly into a rather deep sleep, stage 4 or 5, gradually come up, go through a REM sleep, and go right back down. And this was not known about until, as I say, after World War II. There are other physiological things, variables that have been studied, both with the circadian rhythm and the REM sleep. Dement, by the way, had a very distinguished career. He really is considered the father of sleep medicine. He was a professor of medicine and a researcher at Stanford, and he only died this past June. I personally think he should have gotten a Nobel, but he didn't, and he's dead now, so that's that. A bit of trivia. I know I'm going to skip that in the interest of time. I tend to go down rabbit holes sometimes. So let's talk about how much sleep do we need. Infants need up to 16 hours of sleep, and if they're left alone, they'll sleep about that much. The sleep demand reduces. Adolescents need about 9 hours sleep. Sadly, not many get 9 hours. that's a problem. Adults need, with some individual variation, about 8 hours, give or take. As we get older, we still need that 8 hours, but our sleep efficiency, as it's called, decreases. What does that mean? It means that we have more periods of wakefulness. So we really often need to spend more time in bed to get the same amount of sleep. That's not a disorder, it's just a part of normal aging. It generally, on average, affects men more than women, but any individual may have more or less problem with that. And it's not really a problem, although many people get all worried about not sleeping well because of this normal phenomenon. So it's important to keep in mind for that reason. What happens if you don't get enough sleep? Well, as you might expect, you'll be drowsy, your mental functioning will be impaired, judgment will be degraded, reaction times, other physical things. Chronic sleep deprivation is a risk factor for high blood pressure, stroke, and diabetes. And of course, we're talking really, really long term now. It's a huge risk factor for increased accidents. It's estimated that about 55,000 traffic accidents a year in the U.S. are caused by sleepy drivers, and something like 1,500 fatalities in traffic accidents. So it's a major issue. It also increases the risk of injuries at home, falls, and so on. Inadequate sleep can be the result just of bad scheduling, going to bed too late and getting up too earlier. But as we all know, there are other problems with sleeping. So let's talk about a few of the more common disorders of sleep and wakefulness. We use the term insomnia as sort of a general wastebasket term for problem sleeping with no other specific problem identified. And sometimes that's as far as you get. Probably the most important, medically important sleep disorder is obstructive sleep apnea, which many of you have heard of. Apnea means cessation of breathing. Obstructive sleep apnea, sleep apnea can be either obstructive, occurring in the airway, or central from brain regulation. Obstructive is much more common, or it can often be mixed. We'll say a good bit more about this later because it's important. Another sleep disorder is periodic limb movement disorder, characterized by limb jerks, which may or may not arouse a person from sleep. If they occur while a person's going to sleep, they're called sleep starts. And you're laying in bed and you're dozing off, and suddenly it's relatively harmless, except it's benign, but it can disturb some people. It may coexist with another condition, which is not a true sleep disorder, called restless leg syndrome. This is a fairly common problem in which people any age but more older folks have a restless feeling in their leg, compulsion to move and so forth, sometimes a crawly feeling on the skin. It's relieved by kicking or moving the legs or getting up and walking. As I say, it's not a true sleep disorder, but obviously it may cause trouble going to sleep, and it can coexist with the limb jerks. There are some treatments for that. They're changing. I'm not really up on those, but it is manageable. A fairly common syndrome, really more than a disease, people particularly with some dementia, is called sundown syndrome. In this situation, people who have some cognitive impairment towards the end of the day will get confused and agitated, sometimes disoriented, have acute mood disturbances in the late afternoon and evening. It actually affects up to 2/3 of patients with dementia at some time. And it can be mild and transient, or it can be quite severe and real management problem. It may be worsened by inadequate lighting. It's a little bit like the sort of confusion that occurs with delirium when someone's medically ill and kind of in and out, where a degree of sensory deprivation makes it worse, and just turning on the lights can help some. There are some medication treatments as well. So those are some of the really common primary sleep problems or disorders. There are lots of secondary disorders or causes of disorders. Obviously, any condition involving chronic pain can interfere with sleep. Some types of pain are quite characteristic. For instance, osteoarthritis of the knee, and sometimes other joints, but most commonly the knee is often involved with something called night pain. Your knees are feeling fine. You go to sleep. You wake up with your legs, your knees hurting. A lot of cardiovascular conditions involve dyspnea, difficulty breathing. Some of those are characteristic. Some people with a degree of congestive heart failure can have something called paroxysmal nocturnal dyspnea. Plain English, you suddenly have shortness of breath at night. Some others will have something called orthopnea, which means shortness of breath when lying down flat. A pillow or two will relieve the situation somewhat. And of course, any kind of lung disease can be a problem. Another obvious one, any kind of skin condition involving itching can be a problem with sleep. People with Parkinson's often have sleep problems. Gastric reflux can be a problem with sleep. Many psychiatric illnesses involve sleep problems. The one that's classic and characteristic is the early morning awakening with depression. Depressed people can actually have problems sleeping of any kind, initial sleep disturbances as well, but the one that's classic is the terminal sleep disturbance, meaning waking up early in the morning and not being able to go back to sleep. Folks with dementia are prone to lots of sleep problems, and other major mental illnesses as well, bipolar, schizophrenia at times. Anxiety disorders, post-traumatic stress, PTSD, of course, is famously associated with nightmares. Some medications can cause problems with sleep. Lots of medications have side effects either of making you drowsy or keeping you awake, and it's important to read the package insert and make sure you pay attention to how the drug is affecting you before as you start taking it. Long-term use of sedative and hypnotic medications, sleeping pills, often confounds normal sleep-wake functions, and often, I would almost say usually, cause more problems than they solve if they're used on a long-term basis. Caffeine, of course, can interfere with sleep. This is something that also tends to worsen as we get older. I used to be able to drink coffee all afternoon, and after dinner, sleep like a baby. Now I have to avoid caffeine after about 3 in the afternoon. Chocolate also has a good bit of caffeine in it, and unfortunately, ordering decaf in a restaurant does not always guarantee that you get decaf. You may learn that you didn't when you try to go to sleep. So, what if you don't seem to get a good night's sleep? but none of this sounds familiar. There's nothing that suggests a specific sleep disorder. Here's a list of things that are traditionally called by the quaint name sleep hygiene. I find that kind of a quaint term. We'll just call it advice for getting a good night's sleep. But if you're having any trouble sleeping, you can use this as a checklist. If you're having serious problems sleeping, I would suggest going down the list and making sure you follow each one. A majority of non-specific sleep problems will respond to this list. First of all, and this is probably the most basic, maintain the same time you wake up in the morning, including weekends. No sleeping late on Sundays, even if you stayed up a little bit late. Now, I know if it's New Year's Eve and you're up till 2, no, you're not going to set the alarm for your usual time. But as a rule, get up at the same time every morning. It helps to go to bed at the same time, but because of the circadian rhythm business, getting up at the same time is even more important than going to bed at the same time. And of course, that should allow for 8 hours sleep, maybe with a little cushion for nighttime awakenings. Number 2 is eliminate or decrease daytime naps. If you take short naps and it's no problem, don't worry about it. Again, if you're really trying to go down the line to try to figure out your sleep problem, try going without naps. And if you do nap, whether you have a problem or not, it's well to limit them to maybe 30 minutes. Don't have a nap for 2 or 3 hours. Next, limit or eliminate alcohol intake in the evening and avoid excessive alcohol anytime. Many people who are accustomed to having a glass or so of wine after supper and skip a night are amazed at the difference in the way they sleep, which is telling. Eliminate, obviously, or reduce caffeine intake in the evening, afternoon. Determine your cutoff time, and realize it may be quite a bit earlier than it was earlier in your life. Get at least 30 minutes of moderate exercise. This is important for a lot of reasons, but it is for sleep as well. But don't do it in the evening, especially after supper, and better in the morning or early afternoon. Make sure you get exposure to bright light during the day, and especially in the morning. There are actually, some people have something called seasonal affective disorder, seasonal depression. And there are lights specifically sold to expose you to bright light in the morning. Most people don't need that, but some do. But it's, regardless, just make sure you get some bright light. Next one's important. Use the bed for only 2 things: sleep, and if you're so fortunate, sex. Don't use it for watching TV, for reading. That will not help you sleep well. Also, stop watching screens of any kind, TV, computer, cell phone, at least half an hour, better an hour before bedtime. Don't use bedtime as worry time. If you go to bed, you're not going to sleep, and you realize it, and you're running your head about something, get up and listen to soft music, read a book for a while, not on a screen. And try again. Don't ever stay in bed for more than half an hour awake and not sleeping without getting up and giving yourself a break. If you're preoccupied with something, try some kind of simple repetitive mental exercise. You know, the classic one is counting sheep. I don't know if anybody does that anymore. But you can do some little mental puzzle, or you can do some relaxation exercises. Slow, deep breathing is a good one, or consciously relaxing your muscles, starting with your toes and working up, or with your neck and working down. If you have to get up to go to the bathroom, don't turn on the bright lights. Keep a light by your bed. Don't try to get up in the dark either, because stubbing your toe or falling down won't help. Also, this sort of comes with what I said earlier, avoid heavy evening meals and avoid bedtime snacks. Cookies and milk sounds great at bedtime, but it's not great for your sleep. Aside from going to bed at the same time, try to establish a bedtime routine that sort of tells your Pavlovian mind it's time to go to bed, time to sleep. It'll make going to sleep easier. And control the nighttime environment as much as you can. Comfortable, not too hot, not too cold. Really important, as little light as possible. If you have blackout drapes, great. It's amazing how many little lights on gadgets we have in our rooms, the TV, all sorts of things. If they're bright enough to, after you dark adapt, to notice them giving off light, get some white tape, gaffer tape, adhesive tape, and put as many layers on the light as it takes to just barely be able to see it. You'd be surprised how much that helps. If you can't get good darkness, either because you don't have blackout drapes or you have a partner that stays up reading, try a sleep mask. That works well for some people. So that's the list of sleep hygiene items. And as I say, kind of use it as a checklist. If you just have minor problems and you kind of identify one or two that stands out, try following that. If you're having serious problems, I would just go down the list and make sure you're following all of them as closely as possible. If sleep hygiene is not enough, or if you suspect a specific sleep disorder, you may need a medical evaluation. This could start with the healthcare clinic here, or with your primary care physician. You may need, if sleep, particularly if apnea is suspected, you may need to be seen in a sleep lab, which will involve an overnight stay. It's totally non-invasive, and it will be definitive, and you'll find out what's going on. I mentioned obstructive sleep apnea before. It's very common and it's very medically important, so we really need to say a little more about it. It's amazing that it was only recognized and described in the 1970s. Most of us were full-grown adults by then. It occurs in more than 25% of men eventually, and 20% of women. And incidence increases with age. Nursing home populations, it's much higher than that. So why is it medically important? Well, untreated sleep apnea is associated with markedly increased risk of high blood pressure, and secondary to that, of stroke. That's the big one. It also can contribute to cognitive decline and dementia. So it's a very important issue. People who have short necks and are overweight, are at increased risk, but anybody can have it. Even some relatively young people can have it. Most people who have obstructive sleep apnea are our age, though. Well, I say our age, 50 and up. Symptoms can vary, but most common are morning grogginess with or without a dull headache, daytime sleepiness and fatigue. A lot of the symptoms are due to decreased oxygen levels from obstructed breathing, obviously, but actually more of them are due to carbon dioxide retention. As we don't breathe well, our oxygen levels can go down, but also our carbon dioxide levels dissolved in the blood can go up. And that's what causes the blood pH shifts, and that's what causes the hypertension when it's chronic. It also suppresses something called antidiuretic hormone. Normally in the night there's a hormone that reduces the outflow of the kidneys so you can sleep all night. If that's interfered with, you have to get up to go to the bathroom more, or if you already had to, more still, because of the increased CO2 retention. It can also cause cardiac arrhythmias. If it really is bad, enlargement of the right side of the heart, rarely sudden death. Stroke risk is the big thing, though. If obstructive sleep apnea is confirmed, the most common treatment and the successful one is the use of a CPAP machine. That's an acronym for continuous positive airway pressure. As we get older, bits of our anatomy sag. You may have noticed that. That also happens with the parts of the airway. And it's the same thing that causes snoring. Lots of people start out by snoring worse and worse, and then eventually they have obstructive apnea. If you have a bed partner, he or she will probably tell you of the problem. Full disclosure, I've used a CPAP machine for just over 2 decades. I just celebrated my 21st anniversary, and I literally don't think I would be alive today without it. I have used it every night except 3 in 21 years, and that was because I got out of town and there was some part missing, and I always found a way to get that part by the second night. Okay, the only other thing I want to say is a bit about sleeping pills. This is a term that's been used for any kind of medicine that's a sedative or hypnotic that induces sleep. And as I said earlier, they really, whatever the type, they should only be used for short-term use, and some of them are problematic. I'm not going to go into a lot about that, but I want to mention just a few. There are a lot of over-the-counter sleep aids. Virtually all of them, I don't know of any that aren't, use the active ingredient called diphenhydramine that most people know better as Benadryl. Benadryl's a brand name. And it is a pretty good mild sedative. If you're young, it can be used pretty safely. The problem is, as we get older, it still works, still puts you to sleep or make you drowsy at least. But it exhausts an enzyme called acetylcholinesterase. I won't go into what all that means, but when we're young, it's restored quickly. As we get older, it's a little more sluggish, and the result is that we may be groggy and a little foggy in the morning. Some people might be able to take it one night. If they take it the second night, the next morning they're groggy. In older people, it's associated with a significant increased risk of falls and other accidents. So it's just not a good thing to use if you're older. There are probably the most frequently prescribed sleeping pills now are a group called the Z drugs. They're called that because their generic names all have Z. We mostly know them as Ambien, Sonata, and Lunesta. They're all in a family. They're very effective, but they also have a fairly common side effect called complex sleep behaviors. And what that means is you go to sleep, and without realizing or remembering it the next morning, you get up, you may cook a meal, you may drive to 7-Eleven, all sorts of organized behavior without being aware of it. What could possibly go wrong? A lot. Ambien was introduced in 1993. The FDA finally got around to putting a black box warning on it. Ta-da, 2019, quite a while later. At that time, they reported 20 confirmed deaths and scores of multiple injuries from accidents occurring during these complex sleep behaviors. They are relatively rare. I mean, the deaths and injuries, the behaviors are not. One of my sons had some interesting stories about taking Ambien and doing all sorts of things, cooking breakfast and so on. The injuries are relatively rare because millions of people take but it is something to be aware of. And the only other drug I'll mention is Xanax. It's a benzodiazepine. It's primarily used in treating panic disorder. It's a very potent, very good anti-anxiety drug. Problem is, and it's sometimes prescribed as a sleep aid. Problem is, if you take it regularly for very long, it's the very dickens to get off of. It's a very habituating drug, more so than other benzos for some reason. That's about all I have to say, so let's see what our panelist might be interested in hearing about.
Well, Bill, I think you've actually answered many of the questions I had to ask. I was going to ask about things like Benadryl and wine and that sort of thing. And my main problem or my desire for asking is because I have such a hard time going to sleep. Do you have any more you'd like to say about that? You have said a lot about it. I truly think you answered the questions, so okay. I'm going to let it go.
June. Well, I'm glad I answered most of the questions.
You mentioned all of those.
I would suggest you start by going down the list of the sleep hygiene. You may be surprised at some that you hadn't thought about.
Did you mention melatonin?
No, I didn't.
Okay, and that was one of the questions I was going to ask.
Okay.
Forgot.
Jen would also like to hear something about melatonin, and I'll get to that in a moment. You mentioned the wine, and I had mentioned it, but alcohol in general, it may help you go to sleep, but it is not a good thing for what's called sleep architecture, the structure of sleep, and it will increase your chances of waking up during the night, is the simplest way to put it. So it's not a good idea to have a toddy at bedtime if you're having trouble waking up through the night. Let's see. Well, again, as far as just having trouble going to sleep, I think there's not a whole lot much more to say than
The things you said.
the sleep hygiene list. I didn't mention some people find playing music, soft music, relaxing music in the background. You can set your phone to play it for a certain period of time and then turn off, or just keep it playing. Melatonin. Melatonin is an over-the-counter. It's sold in the U.S. as a nutritional supplement, which covers a wide variety of things that have nothing to do with nutrition. In some countries, it's a drug just like any other. Melatonin is a substance, it's a naturally occurring substance that's secreted by the pineal gland, which is a little bitty pea-sized thing in the middle of your head, that once upon a time was thought to be the seat of the soul by ancient anatomists. Why, I don't know. But melatonin is secreted by the pineal, and it tends to increase in the evening with dark and decrease in the daytime. The melatonin you buy in a drugstore or grocery store is not from ground up pineal glands. It's produced otherwise, but it's the same substance. It's a pretty innocuous substance. It's not a sedative. It's not an hypnotic drug. It does sort of act like you turned out all the lights. It promotes drowsiness. It doesn't make you drowsy like, you know, a sleeping pill does, some of the drugs I mentioned, but it will shift your circadian rhythm in the direction of sleep. Some people, it can be, it usually is used for initial sleep problems. There are extended release versions. Actually, the first one was approved as a prescription drug in Australia a few years ago. It's not a prescription drug in this country. You can buy it easily. It's taken in very small doses, like 0.3 of a milligram to 3 milligrams. And there's some evidence that higher doses are less effective than lower doses, which is kind of paradoxical. They're really the only side effects. Some people will report drowsiness, but I think it's more normal sleepiness. There are some side effects that have been reported with people that took many times the recommended dose. I mean, I don't think you could kill yourself taking the whole bottle for that matter, but you'd probably have some unwanted effects. And long story short, it's generally regarded as safe, as a drug that may help you shift into the getting ready for sleep mode. And it's certainly worth trying, I think, if
Thank you.
Full disclosure, I do have an MD degree. I turned in my medical license several years ago, so I'm not a legal physician anymore.
You can't prescribe it for me.
Well, it's not a prescription drug. You don't need one.
Okay.
So, let's see. Anything else that we need to mention? Thanks for watching, and I hope this one was a little more usable than the one 3 months ago. Good night.